In this video, we will demonstrate the Retzius sparing technique for a non-nerve sparing radical prostatectomy. We start the dissection with the camera 30 degrees down. A horizontal to inverted U-shaped incision is made in the peritoneum just above the rectum. We use sharp and blunt dissection with identification of the vas deferens. The vas is being resected. Also, the seminal vesicle is resected. We do not hang them up with the suprapubic suspension stitch as shown in the classical Retzius sparing technique, because they often tend to fall out during the dissection and are needed to be suspended repeatedly. This is time-consuming. When invasion of the seminal vesicles is suspected, they are put in an endo bag before removal. We use one suprapubic suspension stitch instead of two through the upper aspect of the perioneotomy. We use a Prolene 2.0 on a straight needle. You need this suspension stitch for exposure, but just one is enough. After the suspension stitch, the camera is turned 30 degrees upwards. The fascia of Denauvilliers is incised and you can perfectly choose which plane you will follow to perform an interfacial or extrafacial dissection. Traction on the stump of the vas and the base of the seminal vesicle is performed. The posterior part of the prostate is freed. Here, we will show an extrafacial procedure. Dissection of the lateral aspect of the prostate, leaving the endopelvic fascia unopened when we work nerve sparing. Traction on the prostate is performed upwards and to the contralateral side during the lateral dissection. A wide excision is performed here, hence the non-nerve sparing. Continue this dissection bilaterally until you reach 11 and 1 o'clock position area of the prostate. Start with the dissection of the anterior part. The prostate is pulled downwards and the bladder is pushed upwards. The vertical fibers identify bladder tissue. Dissection is performed making oblique dissection movements. With a good traction on both bladder and prostate, the plane almost dissects itself. Transection of the bladder neck is performed. We do not put repair stitches on 6 and 12 o'clock on the bladder neck as is seen in the classical Retzius sparing technique, because the bladder neck can normally always be identified after the transection. By pushing the bladder neck ventrally, the dissection of the anterior aspect of the prostate can be carried out towards the apex. You can choose to spare the plexus of Santorini by staying very close to the prostate, or transect it when performing a wide excision of the prostate in high-risk or anteriorly located tumors. When the plexus is transected, a running stitch through the plexus is performed for hemostasis after the resection is completed. Apical dissection is carried on until the entire prostate is dissected. We always measure the apical stump. A length of 40 mm or more seems mandatory to gain immediate continence post-operatively in most of the cases. The anastomosis is then started using the von Veldhoven technique, initially on the anterior bladder neck, from outside to in. We use 2 V-lock 3 zeros for the anastomosis. After that, the urethral stump from inside to out. This is then continued till 1/4 of the circumference. After the anterior neck has completed, the catheter is placed in the bladder and the posterior aspect of the anastomosis is completed. A suprapubic catheter is then put in place. We do not close the perioneotomy in contrast to the classical technique, but just let it open.